Okay, this is the Rheumatology and Immunology section of the Pediatric Acute Care Review course. As you can see in the content outlines provided by the Pediatric Nursing Certification Board, these topics are a little bit lower as far as the frequency at which such questions would show up on the boards, but it's still important to review some of the more common disease processes. I do not have any relevant financial disclosures for this presentation. And our learning objectives are just to briefly review the pediatric rheumatologic and immunologic diseases, discuss diagnostic evaluation of such conditions, and identify appropriate management. We'll start with the immunologic diseases. So in order to lay a foundation of thinking about immunologic diseases and different conditions, we need to first think about the immune system. And it's important to remember that there are two elements of your immune system. The first is the innate immune system, and the second is adaptive. So innate is kind of what we are born with, and so it's our neutrophils and monocytes, our macrophages and natural killer cells. Remember that in order for phagocytosis to happen, you need to have neutrophils and macrophages. That's kind of the cells that conduct phagocytosis. We also have a complement system, and that helps attract cells to areas of inflammation and enhance that phagocytosis. And then it's our innate immune system that then alerts our adaptive immune system to the presence of infection. And so when we talk about our adaptive immune system, this is kind of our body's specific response to antigens or foreign substances. And a large part of that adaptive immune system is lymphocytes, whether that be T cells, B cells, and NK cells. Remember that your T cells are considered your cellular immunity. Your B cells, which are less numerous in number, that's your humoral immune system. And then we're not exactly certain of the role of NK cells, but it is kind of the third line of lymphocytes that we talk about. So in an adaptive immune response, the T lymphocyte will bind with an antigen and then trigger a response that causes release of humoral mediators. So remember, that's our B cell component, including cytokines and B cell production. And then that will lead to antibodies that can block the binding of that antigen to cellular receptors. It can help neutralize microbes and also microbial toxins. There are several primary immunodeficiencies, and this is a set of genetic disorders that affect the components of both the innate and adaptive immune system. And this, whenever this is the case, this patient is more susceptible to infection. When we talk about primary immunodeficiencies, we like to identify them and kind of classify them in groups based on where the defect is. And so we'll start with humoral immunodeficiency. So remember, humoral immunity is antibody mediated. So when there is antibody production by B cells, then we get humoral immunity. So this is considered our extracellular space protection. Some examples of humoral immunodeficiencies include X-linked A gammaglobulinemia and combined variable immunodeficiency, or CVID, you may hear it referred to. There's also cellular immunity. So remember, we talked about humoral and cellular immunity and the role of B cells and T cells. So cellular immunity is not dependent on antibodies, but it does involve the T lymphocytes. And so what happens is the T lymphocytes will respond to cells that display MHC markers. And once that happens, there will be a macrophage response, cytotoxic T cell activation, so they'll be working to break down those cells, cytokine release, so you could appreciate some inflammation, and many other processes as part of that cellular immunity. Patients who have combined antibody and cellular defects may be diagnosed with severe combined immunodeficiency, or SCID, and that's like kind of the classic bubble boy that we used to hear about. Wiskott-Aldrich syndrome are other examples of that. There's also phagocytic immunodeficiencies, including chronic granulomatosis disease, or CGD, hyper-IgG syndrome, or leukocyte adhesion defect. And then remember that we talked about the role of complement in the immune system, and you can have either early or late complement defects as well. So the presentation of each primary immunodeficiency really depends on the system that's involved, as you can imagine. So when we think about a patient who has a humoral immunodeficiency, often that patient is recognized due to their history of sinopulmonary or gastrointestinal infections, a history of otitis media, cellulitis, osteomyelitis, and those are most often caused by encapsulated bacteria, including Haemophilus, pneumococci, streptococci, perhaps some parasites, and also enterovirus. When we think about how patients with combined immunodeficiency may present, they may have failure to thrive, they may experience respiratory or gastrointestinal infections, and also candidal skin infections. And so again, the organisms are listed here. So there are the fungal organisms as well as viral, including CMV, EBV, RSV, and parainfluenza. And then from a bacterial perspective, the Mycobacterium species. If we can there. Thank you. If a patient has a phagocytic immunodeficiency, they will often present with severe skin and visceral infections. And the most common organisms include Staphylococcus aureus, Pseudomonas, Serratia, and Klebsiella, and also fungal infection. And then complement, so patients who have complement deficiency may present with meningitis or septicemia, and those organisms may include Neisseria and other pneumococcal species. So how do we evaluate a patient who has a primary immunodeficiency? Well, we want to think about their immune organs. So what's the status of the tonsils, the spleen, their lymph nodes? We also want to consider, are these infections presenting in the presence of perhaps a concurrent process? So are there autoimmune diseases? Is there a malignancy? Do they have a different syndrome that may be related? And do we need to think about that as part of our workup? Initial labs, you can always start with a CBC with differential, quantitative immunoglobulins. You can look at your IgA, IgG, IgM, lymphocyte subsets. So again, that's where we can quantify our T, B, and NK cell subsets. Total protein, albumin, antibody titers. You can measure complement activity, and there's also a nitroblue tetrazolium dye test that can be helpful in evaluating a primary immunodeficiency. The management of primary immunodeficiencies is really dependent on the type of immunodeficiency the patient has. And so you want to think about what antimicrobials may be indicated. You want to think about whether or not the patient would require CMV negative blood products if they require a transfusion. And so that's a processing. Most blood is considered to be CMV safe, but in a patient with an immunodeficiency, it may be really critical that they receive CMV negative blood products. Additionally, you would want to consider whether or not patients required post-exposure prophylaxis. So while most of the population, if exposed to VZV, wouldn't require intervention by us, some special counseling may be required for those patients. And then remember that it's so important to avoid your live virus vaccines. And live virus vaccines include rotavirus, varicella, MMR, oral polio, which we don't use often, or we don't use here in the United States currently, and also the intranasal flu. So in the years that intranasal flu is offered, that may be live, and it's important to think about that. In the following slides, we will talk about specific considerations based on the type of immunodeficiency. So this is management. From a humoral perspective, so these patients, remember humoral, the B cells, it's antibody mediated. These patients may benefit from intravenous or subcutaneous immunoglobulin supplementation. They may be on antibiotic prophylaxis, and special vaccines would not be required for this patient population. Cellular, so remember cellular, one of the combined ones that has a cellular component would be SCID, right, severe combined immunodeficiency syndrome. And so that patient would require a bone marrow transplant. And so, as you know, in a bone marrow transplant, we would completely replace not only the hematologic system, but the immunologic system, and that would afford them the opportunity to kind of be cured of their immunodeficiency. Combined immunodeficiency, these patients will require strict isolation. This is, like I said, kind of a classic SCID. Strict isolation, IVIG supplementation. They'll get prophylaxis for opportunistic infections such as PJP or pneumocystis jirovecii pneumonia, and then those patients would proceed to bone marrow transplant. If a patient has a phagocytic immunodeficiency, again, that PGP prophylaxis, so first line for PGP prophylaxis, is usually trimethoprim, sulfamethoxazole, or Bactrim. You can also use pentamidine, and there are some other alternatives as well for PJP prophylaxis, and then also recombinant gamma interferon. And then finally, patients who have a complement deficiency, you want to prevent infection with vaccines. And so, for example, the meningitis B vaccine is really important. This is human immunodeficiency syndrome, or what we all know as HIV. And so as of 2017, according to the World Health Organization, 36.7 million people worldwide were affected by HIV. It's relevant to us here in pediatrics because in 2018, the most recent statistics showed that 4.2% of new diagnoses here in the United States were in individuals less than 19 years of age. And so especially, when you consider, infections, multi-system illnesses, we in acute care are likely to encounter these patients as well. It's estimated that 51% of people between 13 and 24 years of age do not know they have AIDS. And it's also important to note that this burden in pediatrics has really shifted from the infants who were born with it to the adolescents who are now living with it as more of a chronic condition. Remember that HIV is a human RNA retrovirus, and that there are two types, HIV-1 and HIV-2. The presentation varies depending on the age of onset, and so our infants would often present with viral infections. Perhaps they want to be growing as well, and they can have skin rash, lymphadenopathy, hepatosplenomegaly, and also you would appreciate cytopenias if you were to obtain a CBC with this. And then the older children can have an acute viral syndrome, fever, fatigue, headache, myalgias, arthralgias, pharyngitis, lymphadenopathy, oral and genital ulcers, nausea, diarrhea, rash, aseptic meningitis, weight loss, and sometimes thrush. And these symptoms, the onset of symptoms usually is within approximately 10 weeks of infection, and that's based on the way that their counts are shifting at that time. And we'll talk about the pathophysiology on the next slide. So remember, HIV is a blood-borne virus. It's transmitted via sexual intercourse, shared needles, or from the mother to child, potentially during birth and breastfeeding. HIV is essentially a failure of T-cell production and eventual immune suppression of both cellular, so that's your T cells, and humoral, so your B cells, systems. The diagnosis of HIV, so it's important to kind of differentiate between your screening and then your confirmatory tests. So a high sensitivity ELISA is the screen, and if that were to be positive, then you would want to confirm that result with a Western blot assay. There are also several other tests, that you could run if, in collaboration with your special infectious disease team if you did suspect HIV. Also, it's important that during, when you're managing a patient with HIV, you would assess their CD4 count, and that's a T-cell test, and that indicates how high their risk for infection is. We know that less than 200, actually, that's considered AIDS criteria, but it's important that we would be watching their CD4, recognizing when, that can help guide us on when to vaccinate, and we'll talk about that in the next slide, and when their risks are the highest for opportunistic infection. Remember that we want to screen all adolescents who are considered high risk, all adolescents who are at risk, and if considered high risk, we would screen them annually. So moving on to the management, antiretroviral therapy. So in our infants who acquire HIV, it's important that we start antiretroviral therapy before age 1. Highly active antiretroviral therapy, or HAART, is the principal method for preventing immune deterioration. In some cases, we would want to provide prophylaxis. So again, prophylaxis for pneumocystis jirovecii and also toxoplasma infection. As I said, you'll be monitoring those CD4 counts, and when those counts are the highest, you would want to administer your annual influenza and pneumococcal vaccines to try to prevent those infections in vulnerable patients. Your levels should be monitored every 6 to 12 months when well. And then there are additional screening recommendations now because, as I said, these patients are living for a longer period of time. It's a little bit more of a chronic illness, and so it's important that we're monitoring them for diabetes, osteoporosis, colon cancer, and also lipid monitoring. And really, I think one of the most critical things that we can do as acute care PNPs if we are on any service other than the infectious disease service, is really partner with our special infectious disease teams and ensure that these patients get the highest level of care. We'll move on to the rheumatologic diseases now. So this is a very brief overview of the rheumatologic diseases. Certainly, if this becomes your specialty, your knowledge will grow well beyond this, but this is kind of an adequate overview for the purposes of this course. We'll start with juvenile idiopathic arthritis, or JIA. This formerly was known as JRA. The background, so this is a complex group of disorders. What we know that all of them have in common is arthritis, and there are several subtypes, which we'll talk about in subsequent slides. Based on the subtype, the presentation, the course, and the outcomes will vary. So the definition really of JIA is that the patient has a persistence of arthritis for greater than 6 weeks, and they are less than 16 years of age. It's important that we rule out any other identifiable cause of arthritis, and that we are aware of the fact that there are currently 7 subtypes. Those subtypes include oligoarticular, polyarticular, which can be rheumatoid factor negative or rheumatoid factor positive, systemic JIA, enthesitis-related arthritis, psoriatic arthritis, and then undifferentiated. The pathophysiology is a little bit unclear, and I think largely related to the fact that this is such a heterogeneous disorder. But we do think it's multifactorial, and that there is some genetic susceptibility in the host that then is triggered. These patients present often with joint effusions, tenderness at their joint lines. They can have restricted range of motion, limited movement because of pain. The common feature, as I said, in all of the JIA patients is arthritis. And there are also some forms that are associated with more systemic illness, including fatigue, weight loss, anemia, anorexia, and fever. So in this picture, you can appreciate the actual presence of arthritis. There isn't a single test to diagnose JIA, so when you're evaluating a patient who you suspect may have JIA, it's truly a diagnosis of exclusion, and that's largely made based on the history and the physical exam. And so you want to assess that patient, evaluate all of their joints, perform a really thorough head-to-toe, assess for joint swelling, pain, if they have any limitations in range of motion, either functional or related to pain. If their flexibility is altered, you want to observe their gait, and then also learn about if they have any activity limitations in their day-to-day life. From a laboratory perspective, usually labs will be unremarkable. You can certainly obtain an ANA, a rheumatoid factor, and an anticyclic citrullinated peptide. Remember that if your ANA is positive, it doesn't actually confirm the diagnosis of JIA, but it does help you understand the risk for uveitis. Patients with oligoarticular arthritis, so with less involvement from a joint perspective, will usually have negative laboratory markers. Patients who have polyarticular or systematic onset will likely have elevated acute phase reactants. So when you think about your ESR, your CRP, if you were to obtain a ferritin, so think about your acute phase reactants, those would likely be elevated. And those patients may also have anemia of chronic disease. Complications. So one of the complications that we think about in a patient with JIA is uveitis, which is a chronic non-granulomatosis inflammation of the anterior chamber of the eye. And so we know that certain, as we said, certain tests can help identify your risk for that. So if a patient had a positive ANA, you know that they would be at greater risk for uveitis, and so you may want to advise that they have a little bit different follow-up or monitoring with, in collaboration with ophthalmology. These patients may have poor linear growth, and then also they could have some localized growth abnormalities. And so what happens is at the ossification center of bones, you'll get some accelerated growth, and that'll lead to overgrowth and longer limbs. To the contrary, you could also have premature fusion, which would lead to shortened limbs. And so you could see either of these. As we said, it's a very heterogeneous condition. Also, patients may experience arthritis at their temporomandibular joint, and so in those cases, you may appreciate micronathia, hypoplasia, and also asymmetry. So we manage these patients for kind of a multi-prong approach. So first, occupational and physical therapy can be really helpful. It's important that we optimize their calcium and vitamin D, usually through dietary or herbal supplements. Kind of first line is your nonsteroidal anti-inflammatory drugs from an analgesic perspective. And then from an anti-inflammatory perspective, corticosteroids are often used. We can, in more severe cases, use disease-modifying anti-rheumatic drugs such as methotrexate. And nowadays, and you all know this from having been in school and in the clinical setting, but biologic agents are gaining a lot of attention and being utilized in many more settings now. And so you've got TNF-alpha inhibitors such as etanercept or Enbrel or infliximab and Remicade. There are also interleukin inhibitors like the anakinra that we hear about for these patients, and also targeted therapies that will target your T cells or your B cells. There's also, from a rheumatologic perspective, systemic lupus erythematosus. And so this is a chronic autoimmune disease that can involve any organ system. The incidence is highest in females, and it does increase in age. We know that non-whites are affected more often and more severely than their white counterparts. So in general, we know that SLE affects about 0.3 to 0.9 people per 100,000. In childhood, often these patients experience more acute and more severe cases. And as I said, it does affect females more often than males. So in children, the female to male ratio is 4 to 1. But after puberty, the male to female ratio changes quite a bit. And so females are affected 8 to 1 compared to males. So that discrepancy is pretty significant, especially after puberty. On the median onset, so patients usually present between 11 and 12 years of age. And from a pathophysiology perspective, we know that HLA class 2 alleles, so DR2 and DR3, and also complement deficiencies may contribute to the development of this disease. And so this genetic component, they have determined that certain HLA haplotypes, so when we look at their DNA, may increase susceptibility. Also, when we think about, family involvement, family history, what's relevant here to obtain, about 1 out of every 10 families of a lupus patient will have some other history of a connective tissue disease, not including lupus. So the clinical presentation of SLE, these patients will have a malar rash that often, just of note, will increase in intensity when they're exposed to sunlight. They can also have a discoid lupus rash. They may be photosensitive, have arthritis, nephritis, so they may have proteinuria and also cellular casts on urinalysis. They can present with encephalopathy, like seizures and psychosis, pleuritis or pericarditis. They can have cytopenias, and then their immunoserology may be positive. So when you look at their DNA and anti-Smith antibodies, those may be positive. We know that also in children, the fever, rash, fatigue, and joint pain is the most often presentation, or most typical presentation, I'm sorry. The presence of 4 of these criteria that are outlined on this slide has a 96% sensitivity and 100% specificity of childhood lupus. So on this slide, you can appreciate that discoid rash that we referred to in the previous slide. And here we've got that malar rash, and so you can see this erythematous maculopapular rash. It covers the malar areas, extends, you can see over the bridge of the nose and the cheeks. It can spread down the face and the extremities. You can see that it spares kind of perioral, that area, and also periorbital. This rash may be photosensitive, as I mentioned before, and it's important to note that this rash is present in about 95% of patients with SLE. So the clinical presentation, I think we kind of largely just covered this, but again, it can be acute or subtle. And I'll just kind of highlight some of the things that we didn't previously describe. But from a renal perspective, the patients, in addition to that proteinuria and the cellular casts, they may have glomerular nephritis and nephrotic syndrome. And then we talked about the neurologic involvement, but headaches, seizures, psychosis, cognitive dysfunction and mood disorders may be present. Again, from a hematologic perspective, you may see hemolytic anemia in addition to the cytopenias. And then from a GI perspective, the patients may have abdominal pain, autoimmune hepatitis, pancreatitis, and protein-losing enteropathy. The endocrine system can also be affected in the form of hypothyroidism, delayed puberty, and irregular menses. And then we talked a little bit about, pericarditis, pleuritis. Patients may experience interstitial pneumonitis and also pulmonary hemorrhage in severe cases. And then they may present with vasculitis and thrombotic thrombocytopenia as well. When you're thinking about diagnosing a pediatric patient with SLE, it's important to note that over time, they would be required to have 4 of those 11 diagnostic criteria. And if you were performing a laboratory evaluation, you would obtain autoantibodies, including your anti-nuclear antibodies and anti-Smith antibodies, as well as a CBC with differential. And again, you're looking for cytopenias and evidence of a hemolytic anemia, your serologies that you could send, and also inflammatory markers. And you would expect to see an ESR. So the management of a patient with SLE is largely based on the symptoms and the affected organs. You can immunosuppress them certainly using corticosteroids, again, those disease-modifying anti-rheumatic drugs that we talked about previously. You could use mycophenolate mofetil or Cellcept, cyclophosphamide, which is a chemotherapy agent, but it has pretty good activity. Monoclonal antibodies as well. So when we think about all of those mAbs that are now being utilized for treatment of rheumatologic conditions, those could be employed here as well. From an immunization perspective, it would be important that these patients are immunized against influenza, pneumococcal, and meningococcal as well. And remember that in addition to their disease, which has some immune component, you're immunosuppressing them with their therapy, and so it'll be really important to provide those immunizations and also provide them with adequate education that they can recognize evidence of infection and then present for intervention, because they could become very ill very quickly, as you know, with all immunocompromised hosts. And then you want to monitor for comorbidities as well. Just one slide about neonatal systemic lupus erythematosus. So this is a transient syndrome. It's what often happens is that you have a mother who's not diagnosed with lupus, and she passes the lupus via her placenta to the neonate, and so that neonate then has it. The neonate may present with heart block, rash, thrombocytopenia. They can have abnormal liver function tests, and they may also have a Coombs-positive hemolytic anemia. This is thankfully a transient syndrome, but just of note, something that some of you may encounter. Kawasaki disease, and so we'll talk for a minute about the pediatric vasculitides. This is the second most common pediatric vasculitis. It does affect the small to medium vessels, and it does occur more often in males. We know that this affects children less than 5 years of age the most often, and that they really contribute to 90% of cases of Kawasaki. And although we're not completely certain of the etiology, we do hypothesize that there is an infectious, immune, and genetic component that may play a role. So the definition, as you guys know, this is inflammation of the blood vessels. And the things that we really worry about in Kawasaki are those coronary artery aneurysms. And so as those blood vessels inflame, it can lead to necrosis and arterial aneurysms. And it's really the coronary ones that are of the greatest risk for these patients. There is some specific diagnostic criteria. So in addition to the presence of a fever for 5 days, for a diagnosis of classic Kawasaki, the patient should meet 4 to 5 of these criteria. So that would include bilateral painless bulbar conjunctival injection without exudate. So you'll see those like pink injected eyes, changes to the lips or the oral cavity, and this is where we see that strawberry tongue, dry, cracked lips, very pink lips, injected oral mucosa, a polymorphous exanthem, often unilateral cervical lymphadenopathy, and usually that's a node measuring greater than 1.5 centimeters. You could also see changes in their peripheral extremities or the perineal area, sometimes in the palms of the hand or the soles of the feet. these patients will have some initially erythema and edema, and then that often transitions into a peeling or desquamation during the convalescent phase. And so when we talk about the phases, the acute febrile period, this is a triphasic disease. So the acute febrile period is usually up to the first 14 days. And then there's a subacute phase of about 2 to 4 weeks, and then a convalescent phase, which lasts months to years. It's also important to note, we talked about the specific criteria, so you know that for a classic diagnosis, 4 to 5 of these are required. For an atypical or incomplete diagnosis, they would have 2 of the criteria. There are some additional symptoms, and they're listed here based on the system that's involved, but certainly the cardiovascular system is of some of the greatest concern for us. These patients may also present with abdominal pain, nausea, vomiting. They can have arthritis. They may have transverse furrows of the fingernails, or what's called Bowes lines, which we'll see in a slide. And then also they can present with irritability, headache, and aseptic meningitis. So this is that kind of classic, you can appreciate, injected sclera. There's no exudate bilaterally. You can see also these lips look very pink or very red, and you know, they may again appear dry or cracked in your patients. These are Bowes lines, so you can see the transverse furrows of the fingernails, and that's what we are referring to when we say Bowes lines. When you obtain laboratory tests on these patients, you will often see leukocytosis on their CBC, and their neutrophils will be elevated as well. When you look at their inflammatory markers, their ESR and CRP will be elevated. You may also see elevated platelets, transaminases, so your ALT and AST will be elevated, and also your GGT. They can have hypoalbuminemia and also anemia. And then from a radiographic imaging perspective, it's really important that you obtain echocardiographs on these patients. And so you want to evaluate for coronary abnormalities, including dilation, stenosis, and aneurysms, and also monitor for decreased ventricular function. When we talk about obtaining echocardiograms, there's a recommendation that you get it at diagnosis, at 2 weeks, and then again at 6 to 8 weeks post-diagnosis to really follow that and evaluate for the development of coronary abnormalities. You can also obtain a chest radiograph to evaluate for cardiomegaly. From a management perspective, it's important that we try to diagnose these patients promptly so that we can start our intervention. Intervention may include IVIG, 2 grams per kilo. Also high-dose aspirin, so 80 to 100 mg per kilo per day, and then that will be weaned as their fever effervesces. So once they're afebrile, you can decrease that to a dose of 3 to 5 mg per kilo per day. And then long-term therapy is really going to vary based on the risk level. And in previous classes, we had some questions because we know in pediatrics we often try to avoid aspirin given the risk of Rett syndrome in pediatrics, but what they really found, or what the literature recommends, is the use of high-dose aspirin in these patients given the risks of coronary aneurysms and abnormalities. So it is indicated in such conditions. And then we will move to anaphylaxis. So again, when we're thinking about immune response and, you know, all of kind of everything that fits within this umbrella, it's important that we also think about anaphylaxis. So this occurs most commonly among children and adolescents, and the incidence is certainly on the rise, although thankfully the fatal cases are rare. It is a potentially life-threatening systemic reaction to an allergen or a trigger, and it primarily affects the mucocutaneous, hemodynamic, and respiratory systems. I think that we often think about, you know, the patient who ingests an allergen, a peanut or something, for example, or is stung by a bee and develops anaphylaxis. But I think it's also important to remember that those of us in acute care are practicing in environments where we are administering blood products and, you know, new pharmacologic agents, and the risk for anaphylaxis is kind of always in our practice. So it's important to always review this and, you know, stay current on the recommendations. Most common triggers include food, medications, and insect stings. There are a variety of mechanisms, and so you could have IgE-mediated or not. It could be non-immunologic, and it can also be idiopathic. It doesn't actually matter, and we don't even always tease that out because all of the mechanisms are treated identically. There is often a rapid onset, so we describe it occurring from minutes to hours. And these patients may have urticaria, angioedema, abdominal pain, emesis, wheezing, stridor, laryngeal edema, hypotension, and shock. Remember that it doesn't always present with mucocutaneous swelling. Sometimes it will present with that abdominal pain and cramping. So just important to think about. Remember also that if this isn't treated promptly, it can lead to complete cardiovascular collapse. So there is no diagnostic evaluation per se. This is a clinical diagnosis based on symptoms, and it's one that you will very rapidly identify and intervene on. There is no specific laboratory testing, and certainly we wouldn't recommend that if a patient presents with anaphylaxis, you try to obtain these levels, although if you did, you would expect that your plasma histamine, serum tryptase, and serum IgE would be elevated. Once a patient does experience an anaphylactic reaction, subsequent skin testing may be indicated if you're not certain about, or if you want to confirm the allergen or triggers that they were exposed to. That would be obviously a little bit less common in the inpatient acute care setting where it's induced by something that we've administered. This is more for the patients who present from the community to our emergency department and will require a referral later. When we talk about clinical criteria for anaphylaxis, so there's just a couple different ways that we define this. And I think this is probably less important than recognizing how to intervene on anaphylaxis. But the first is that you have an acute onset of skin or mucosal involvement, but you didn't recognize that there was a trigger. So the patient doesn't have a history of allergies. There isn't anything known that would have caused this reaction. However, their skin and mucosa are involved, and then they have either respiratory compromise or they could have reduced blood pressure or symptoms of end organ dysfunction. So that's one of the criteria. The other is where there's a known exposure and you have 2 or more rapidly occurring symptoms, and that could include skin or mucosal involvement, respiratory compromise, reduced blood pressure, symptoms of end organ dysfunction, and persistent GI symptoms. And then the third criteria is just where you have a rapidly reduced blood pressure after a known exposure. And that's kind of on its own. Management, as we said, it really doesn't matter what type of reaction this is or what it was, what clinical criteria it satisfies. You're going to follow your ABCs. First, you want to discontinue that exposure, again, especially relevant in the inpatient setting. You would want to administer epinephrine. Remember, do not delay if anaphylaxis is suspected. That's one of those where if you think it, you should do it. You want to administer either IM or sub-Q, and this is all recommended based on, our PALS guidelines from the American Heart Association. You can repeat epinephrine, remember, every 3 to 5 minutes as needed. Often those patients will require a fluid bolus because they may become hypotensive. And you can give other agents such as diphenhydramine, albuterol, a corticosteroid, and also an H2 blocker like ranitidine or famotidine in the setting of anaphylaxis to help otherwise care for those patients. That's the conclusion of the review of rheumatology immunology for this course. If you have any questions, please do contact me, and I would be happy to try to answer those as well as I